Hello everyone, Dr. Matt Ed. Today we'll talk about myocardial infarction with non-obstructive coronary arteries, also known as MINOCA, and ischemia with no obstructive coronary arteries, also known as INOCA. Today we'll talk about the difference between MINOCA versus INOCA, and we'll describe the causes, clinical features, diagnosis, and management of both. We will first talk about MINOCA. The definition of MINOCA is acute myocardial infarction with angiographically no obstructive coronary artery disease or stenosis of less than 50%. Therefore, it is diagnosed after coronary cath. This entity is diagnostically challenging and complex, making it difficult to manage effectively. MINOCA disproportionately affects females and may account for up to 50% of all MIs in younger women less than 55 years of age. The proportion between women and men is 5-1. It mostly affects patients who are Black or Hispanic, and these patients are less likely to have cardiovascular risk factors including hypertension, dyslipidemia, diabetes, and current smoking history. The pathophysiology at the epicardial vessels level include coronary artery spasm, myocardial bridging, acute thrombosis of non-obstructive plaque. So for these, the atherosclerotic plaques expand outward rather than into the lumen. They are often lipid-rich and have a thin fibrous cap that are vulnerable to rupture into the lumen, and when that happens, it's a transient and partial thrombosis with spontaneous fibrinolysis and distal embolization into the coronary microcirculation, and spontaneous coronary artery dissection, which is associated with fibromuscular dysplasia. These are causes from the microvascular circulation and also includes MINOCA mimickers. And this includes Takotsubo cardiomyopathy, viral myocarditis, and also coronary microvascular dysfunction, which causes transient myocardial ischemia with associated ST segment changes, and patient will also complain of angina. And also coronary artery microvascular embolization, which I spoke about in the prior slide. And these patients and risk factors for these patients include prosthetic valves, atrial fibrillation, apical thrombus, infective endocarditis, coronary artery aneurysms, rheumatic heart disease with mitral stenosis, and atrial myxoma. These are MINOCA mimickers, as most of the time they will have high levels of troponin and angiographically normal arteries. The clinical presentation is similar to that of patients with acute coronary syndrome with obstructive CAD. And electrocardiogram and biomarker testing mimic those of patients with atherosclerotic coronary obstruction. So the diagnosis and workup. When a patient comes in and they meet the criteria for acute MI, but with no major luminal irregularities at the time of coronary angiography, such as there are no lesions obstructing the luminal diameter by greater than 50%. Then the patient can be diagnosed with MINOCA. If it is non-obstructive atherosclerotic CAD with stenosis of less than 50%, then one should evaluate for evidence of acute thrombosis with intravascular ultrasound or optimal coherence tomography. Afterwards, can also look for causes of MINOCA as outlined in prior slides, such as transthoracic echo, cardiac MRI, provocative coronary testing, or hypercoagulable workup. To assess vasospasm, intracoronary injection of acetylcholine, which is invasive during cath. It is positive if reproduction of chest pain and there are ischemic EKG changes. And also, if the vasospasm constricts the coronary artery lumen by greater than 90%. Then epicardial vasospasm is diagnosed. And if not, then microvascular vasospasm is diagnosed, given there is reproduction of chest pain and ischemic EKG changes after injection of acetylcholine. To assess microvascular disease and dysfunction, it is done by testing the coronary flow reserve with a Doppler wire, which is also invasive. This is a table that summarizes further diagnosis and diagnostic workup of MINOCA. So these are already outlined in the prior slides. For example, coronary thrombosis and rapid clot lysis. It can be diagnosed or worked up with CAF and IVUS. Micro and macro emboli can be checked with TTE or TEE. You're just looking at the left atrial appendage and also the valves, or if there's endocarditis. Vasospasm can be diagnosed with history. Invasive testing include acetylcholine provocation testing. Hypercoagulopathy, one will screen for thrombophilia disease. Vasculitis, check for ESR-CRP. Coronary microvascular dysfunction, can check a PET or coronary flow reserve. Myocarditis can be ruled out with cardiac MRI, ESR-CRP. If the patient has PE, check CT, PE. Cardiomyopathy such as Takotsubo's, one can check an echo or cardiac MRI. This is an overall flow chart of what we spoke about so far. So MINOCA is a universal AMI criteria when it meets, plus no angiographic stenosis of greater than or equal to 50%. So one will take the patient for CAF since he meets criteria for MI, and the CAF is pretty much non-obstructive. And one would then consider reviewing or subtle missed angiographic findings, including coronary dissection, look at emboli or plaque disruption, and intracoronary nitrates if there's suspicion for coronary vasospasm. And then afterwards, consider LV-gram or echo to look for Takotsubo or other cardiomyopathies, heart failure, IVUS or OCT to look at plaque rupture, erosion, or you can also look for dissection as well. Pressure Doppler wire to assess for microvascular dysfunction, and provocative spasm testing to look for coronary spasm. And of course, not in an acute phase of AMI. And laboratory testing include looking for type 2 MI, D-dimer, thrombophilia screen, BNP to assess for heart failure. And these are the MINOCA etiologies that can be diagnosed or thought about. But if there is no diagnosis confirmed afterwards, we can investigate using cardiac MRI to look for myocarditis, and a TEE to look for cardioembolism source of emboli. The specific treatment of MINOCA is specific to the underlying cause. There was an observational study from the Sweetheart Registry which showed that there was a benefit with statins, ACE, ARBs, and beta blocker, but neutral with dual antiplatelet therapy. However, it was only an observational study. So if the patient was found to have plaque disruption, then we would treat them with dual antiplatelet therapy, statins, ACE, or ARB. If there's coronary vasospasm, then the treatment is calcium channel blockers and nitrates. Thrombosis or embolism, we treat the underlying hypocoagulable state in a heme consultation. Spontaneous coronary artery dissection, that's treated with beta blocker and aspirin. However, we also consider dual antiplatelet therapy. Microvascular dysfunction, so treatment is if there's spasm, we treat with calcium channel blocker, avoid beta blocker. Coronary function reserve is low or high, index of microcircular resistance, then that will be treated with beta blocker, ACE, or ARB. So microvascular dysfunction is diagnosed if the coronary flow reserve is less than 2 or index of microcirculatory resistance is greater than 25. supply. If there's supply-demand mismatch, such as a type 2, then we would treat the underlying disease. So CFR here stands for coronary flow reserve, and IMR here stands for index of microcirculatory resistance. There was a study showing in-hospital mortality was 0.9% and a 12-month mortality was 4.7%. Given the heterogeneity of causes, studies of the prognosis of patients with MINOCA are of limited value. Here we'll quickly talk about ischemia with no obstructive coronary arteries, also known as INOCA. So the definition is ischemia caused by a lack of blood flow to the myocardium, which causes a supply-demand mismatch. That's the definition. And diagnosis of INOCA is confirmed, and diagnosis of INOCA is when the coronary artery disease as a cause of anginal symptoms is excluded. Causes of INOCA include coronary artery spasm, microvascular disease, coronary artery anomaly. And the clinical presentation is similar to that of angina from obstructive CAD. And diagnosis and management is similar to MINOCA. And my reference is from Up to Date. If you thought this video was helpful, please like, subscribe, and look out for my next video. Thank you for watching.